So how do you identify these factors? The answer is a sex status. So you're like a sex detective when you're doing this kind of work. A good sexual status gives you like a videotape, a video picture in your mind about the friction, frequency, fantasy, and feelings the patient is experiencing. It'll allow you to identify the factors that are currently maintaining the distressing sexual disorder. This is critical. We're looking at the here and now, what's currently interfering with that person's ability to function. There may have been all kinds of psychosocial, historical issues that would be of very interest dynamically to a dynamically oriented therapist to try and uncover and help the patient understand. But that's not what we're doing. This is sort of top-down rather than bottom-up. Depending on the patient's responses and comfort level, as well as your own, because some people find it difficult to speak explicitly about sex, probe for the needed details and sexual experiences that illuminate the key factors. These details do raise the question of how interactive do you want to be? Who do you wish to be as a therapist? Can one work dynamically this way? Helen did, and she was a psychoanalyst, but then again, she became more directive as time went on. So it's your choice, but if you're knowledgeable about how to do this, you'll have the capacity to treat yourself, and you still have the option, if you prefer to maintain a particular frame, of referring out for adjunctive sex therapy. So I always ask this one question. I ask about their last sexual experience. And one young Orthodox Jewish couple took real exception to this. He had never ejaculated. He was referred to me by his urologist because they were planning to electro-ejaculate him so they'd be able to do artificial insemination. And this very young couple, 19 and 20, would be able to have their first child. So they come in to see me, I ask them this question, and they start talking Yiddish to each other and giving me dirty looks. And then, the guy says, just because we're Jewish doesn't mean we're not normal and that we don't do it in the normal way. And I say, oh, I'm Jewish also. And they go, yeah, but we're Jewish, he says to me. But I ask him anyway, I said, this is really the only way I can help you is if you can tell me a little bit more about it. He goes, well, like I said, we do it in the normal way. I go inside her and I wait. I go, okay, and then what happens? He goes, I wait some more. I say, and then? He says, well, I wait some more, and then it gets soft, it falls out, and we try again the next day. So I say to him, do you ever move? I use my fingers a lot, when I'm talking sometimes. And you see the light bulb go off on these young people's faces. We schedule a follow-up appointment. I had told them that you might want to try this, certainly before you do the electroejaculation. They come back in to see me. They tried it a couple times, didn't work at first, but by the third time, they were able to have successful sex, and they were very, very happy. We schedule a follow-up appointment, and not surprising to any of you who've worked with couples from this particular population, they canceled the appointment and, never heard from them again, despite attempting to reach out to them. So I hear from the urologist who made the referral that she's pregnant, it's a couple months later. Turns out she ended up having 8 kids. Now, how do I know about this? Because every year at this time, a box would be delivered, a box of matzah from Brooklyn with a note that said, Dear Dr. Perlman, you and your family should have a very kosher Passover. And thank you. So what are the critical evaluation issues? I'm asking you to get a lot of material. How do you know what's critical or not? First of all, do they have a sexual disorder? What's the diagnosis? Second, what are the underlying biomedical, psychosocial, and cultural factors? Just because you're going to start with what's maintaining doesn't mean you don't want to have some understanding of what else is going on. And importantly, do any of those underlying factors require pre-treatment, or can they be bypassed, modified, or treated concurrently? For instance, severe depression. Some of you are going to be more comfortable treating that than others. Severe marital conflict, drug or alcohol abuse. Usually these things require some pre-treatment before you can go and focus on the sex. So people who we've trained are able to do both. Other people are more likely to refer out. for those treatments. Again, you want to identify the factors that are predisposing, precipitating, exacerbating, or maintaining the disorder. And where do you begin? As I said, you begin with the immediate cause that are currently maintaining the problem. Resistance to that, which is inevitable, will occur to behavioral suggestions. It's not like you tell them what to do and they just come back the next week and it's a success. But that's going to illuminate deeper causes, which can be bypassed or, again, explored as needed, and then you return to more of a directive treatment.